Welcome. Welcome to our second nurse webinar of 2018, Nursing Solutions, Non-Pharmacological, Complementary, and Alternative Practices in Parkinson's Disease. We're going to discuss what we know about their impact on quality of life and actual patient practices. These nurse series showcase the work of our nurse scholars who completed the Edmund J. Safra Visiting Nurse Faculty Program at Parkinson's Foundation. Today's webinar features two of our scholars, Dr. Fang Yu, Associate Professor, University of Minnesota in Minneapolis, Minnesota, and Dr. Yusheng Shin, Associate Professor, University of Delaware, School of Nursing. You'll hear a bit more about our speakers right before their presentation. First, a little housekeeping. The PowerPoint slide deck can be downloaded from the reminder email you received this morning or from the Parkinson's Foundation webpage highlighting this talk, or on the page you're looking at to the left. Health professionals can earn one free continuing education credit through the American Society on Aging. Participants will receive an email after today's webinar with steps on how to collect the CEU. You have just 30 days when the CEU is available, that is until June 15th, to collect this free continuing education credit. Next slide, please. In way of an introduction to our program today, Parkinson's disease is a common and chronic disorder which often spans over decades of life for an individual. There's no current cure, although there are very good treatments. Conventional medicine and treatments are very helpful and certainly very necessary, but patients and families often seek additional options. Next slide, please. You may hear the terms conventional, complementary, alternative, or integrative. These terms are often used interchangeable, but there are some distinctions that I just wanted to mention at this time. Conventional treatments refer to a traditional medical doctor or healthcare professional visit, which offer prescriptions, surgery, and the like. Complementary therapies are used in conjunction with conventional. Alternative therapies, by definition, are used in lieu of conventional. And integrative are conventional and complementary used together in a coordinated manner. Non-pharmacological treatments are those therapeutic measures that are not related to drugs or medicines which are ingested, injected, or otherwise absorbed in the body. So while we often use these terms interchangeably, I thought it might be helpful just to go over some of the definitions that are used in the science. Next slide, please. Worldwide, and certainly in the United States, the use of complementary and alternative and integrative medicines has been going on probably since the beginning of time. However, in the 1990s, in fact, in October of 1991, a public law was signed, and that allocated $2 million to investigate and evaluate promising unconventional medical practices. That was one of the first laws that Congress gave funding for actual study of these practices. In 1998, the National Institutes of Health established the National Center for Complementary and Alternative Medicine to further evaluate safety and efficacy of these measures and also to train researchers and report to the public. In 2012, there was a National Health Interview Survey done, and at that time it was found that 33.2% of adults use some form, or if not multiple forms, of complementary or alternative medicine, spending $30 billion yearly on visits to practitioners or to purchase the products. In 2014, the name changed at the National Institutes of Health to the National Center for Complementary and Integrative Health. Last year, the National Center for Complementary and Integrative Health had an allocation of $130.5 million in funding, and they are currently studying 49 studies, funding 49 studies. Next slide, please. So these studies that are being funded and on the national level by the National Institutes of Health cover mind and body practices such as pain, stress, anxiety, healthy behaviors, and include things such as acupuncture, massage, meditation, Tai Chi. They also look at natural products, which include herbs, botanicals, dietary supplements, all the while studying any interactions, studying the safety, the biological effects, and the mechanisms of the practice or treatment or product. Next slide, please. Our objectives for today are to display and understand the meaning of non-pharmacological, conventional, complementary, alternative, and integrative practices, and to become familiar with the current research on these practices, specifically in Parkinson's disease, and their findings on the impact on quality of life. We will also discuss what practices Parkinson's disease patients are actually using and factors which may influence patient choices. Next slide, please. So at this time, I would like to introduce our first speaker, Dr. Yu. Dr. Yu holds a doctorate in gerontological nursing and is a gerontological nurse practitioner. She completed a John A. Hartford, Claire M. Fagan Building Academic Geriatric Capacity postdoctoral fellowship and is currently an associate professor of nursing at the University of Minnesota in Minneapolis, Minnesota. Inspired by her clinical practice in both China and the United States, Dr. Yu has focused her research, teaching, and service on improving the health and healthcare delivery to older adults, particularly those with Alzheimer's disease and Parkinson's disease. She has received many federal, state, and foundation grants for her research work and published in multiple peer-reviewed journals and book chapters. Her professional achievements have earned her several awards, including induction as a fellow in the Gerontological Society of America and the American Academy of Nursing. Dr. Yu is a 2016 scholar of the Edmund J. Safra Visiting Nurse Faculty Program at the Parkinson's Foundation. Welcome, Dr. Yu.
Thank you, Gwen, for the introduction. I'm really happy today to share with you the project we did for the Visiting Faculty Scholars Program, which is to look at quality of life as an outcome in non-pharmacological interventions in Parkinson's disease. Next slide, please. So why do we want to look at quality of life as a main outcome in research and practice? And there are several main reasons. First of all, we know medications and surgical interventions have been demonstrated to be really effective on motor symptoms of Parkinson's disease. However, their impacts on non-motor symptoms are controversial, and also they are not without side effects for certain patients. Secondly, for non-motor symptoms, there are really no clearly demonstrated medication effects. And some of the medications that are currently being used to treat non-motor symptoms actually may interfere with drug effects for motor symptoms. And sometimes they can even aggravate motor symptoms. Whether or not patients are undertreated or overtreated, we know they both lead to poor quality of life. And currently at the National Institutes of Health, one of the major initiatives is to have patient-reported outcomes. And quality of life is one such domain that reflects patient-reported outcomes. So that's why we use quality of life in our literature review. Next slide, please. So how did we do the literature review? We look at 3 electronic databases, PubMed, Signal, and PsycInfo. And we use the medical subheadings of Parkinson's disease, therapy, and quality of life, combining those to get the articles, which generated 302 articles. We also conducted a manual search by looking at the publication references from the electronic papers to identify additional articles that yielded another 14. So after removing the duplicates, we have roughly 200 some articles left. And then we apply the inclusion and exclusion criteria. The inclusion criteria were mainly publication in English. They treat quality of life as an outcome. And it's an experimental study, which means they actually tested a non-pharmacological intervention. Then we excluded studies that are drugs or surgical interventions or simply case studies. Of the articles we reviewed, we excluded 233, and the final pool of study articles are 26. And for those 26, we use this EPHPP quality assessment tool to evaluate what's the quality of each study. Next slide, please. Can we please? Okay. So what did we find? First of all, we found 9 of the 26 studies were conducted in the United States, 1 in Brazil, and the rest of the studies actually were scattered across Europe. And basically 1 study from several countries, and then there were 4 studies from Netherlands. If you look at the pie chart on the right, that look at the quality of those studies, it showed about 50% of the study really have strong quality. And then 15% had moderate quality, and then 35% has weak quality, 15% have moderate quality. So now we are at the slides that's being shown as what interventions were tested. So actually it was a very good news. We found a variety of interventions that were tested. Oh, can we go back to slide 11? So we are actually on this what interventions were tested slide. So the most studies, about 57% of them actually tested an exercise intervention. And then for the other interventions, there was only 1 study per intervention. But you can see here there are 11 different types of interventions that were tested, including acupuncture, neuromuscular electrical stimulations, patient education, reflexology, self-management, spa therapy, cognitive training, cueing training, music therapy, neuromuscular therapy, and physiotherapy networks. And then if you look at the outcomes, quality of life, how it was measured, the majority of the studies actually measured it as primary outcome, and the other studies measured it as secondary outcome. This is very important when it comes to result interpretation that I'll mention later on in the slides. If you look at what exact instrument was used to measure quality of life, this pie chart shows that the majority of the study used the Parkinson questionnaire 39 as the outcome measure, and then the 15% used the PD quality of life scale. Next slide, please. So what did we actually find out from this literature review? This is slide number 13. How did the interventions affect quality of life overall? Could you please advance 1 slide? Thank you. So basically, the majority of the study, not vast majority, but 58% showed that the interventions significantly improved quality of life. although 42% reported no effect. But remember I mentioned earlier, this result actually is reflected by whether or not quality of life was measured as primary outcome or secondary outcome. When people do research and they measure primary outcome, typically they have some ideas where they did a sample size calculation to determine what's the sample size needed to see a major change in the primary outcome. In this case, quality of life. So when we look at the studies that look at quality of life as primary outcomes, the results are very positive. They all showed some improvement, even modest to moderate improvement on quality of life. However, if they treated the quality of life as secondary outcomes, which basically means that they either didn't do a sample size calculation on quality of life, or it was a secondary measure that didn't pay enough attention to it. So the sample size were usually small. As a result, they weren't able to demonstrate a change in quality of life. Next slide, please. So this slide is very busy, as are the slides following it. So it's not really intended for us to go through them. But basically, I'm providing you a summary of the 26 studies so you can see what exactly was the intervention, how they did it, and whether or not it showed any significant change. And if you look at the left column, after each article by author's name, you will see what level of evidence this is and what is the quality of this particular evidence. So this is basically a take-home slide for you to review in detail. And the second slide, for purpose, you can see we detailed exactly what the intervention was. So you can, if you want to use it in your practice or for patients and family who want to do it, you can see what could be a starting point for you to engage in those type of interventions. So let's go to slide number 16. So again, same thing, and we should go to slide number 17. Thank you. So based on this literature review, what conclusions can we get from this? What's your take-home messages? So basically, the number one message is there are a variety of non-pharmacological interventions that have been studied for their effects on quality of life in Parkinson's disease. Even though there was only one study for 11 interventions, it's a very good sign that people are actively looking at different variety of interventions that could work for this population. And there was very promising initial results when quality of life was treated as the primary outcome. The small sample size most likely explained the insignificant results. And we definitely need more studies for each intervention to better establish the scientific evidence. If we come down to look at the interventions, the majority of them, 15 of them actually, were focusing on some type of exercise. For example, they look at aerobic exercise or endurance exercise, strength training. They also look at balance exercise, boxing, dancing, different modalities. And the exercise doses actually vary considerably. So what do we need to go next? For research, it means we have to look at those interventions and determine what is the minimum effective dose that we should have to affect quality of life in Parkinson's disease. And then further establish the optimal effective intervention dose for affecting quality of life. And that should be done for each of those interventions from scientific perspective. Then for practitioners or patients, what this means is basically you can think about those interventions and whether or not you like them or you want to try them. I think it is worth trying them even though the evidence is not necessarily there to support it yet. Next slide, please. So I want to thank my co-authors who contributed to this work. I specifically want to thank the Parkinson's Foundation and the visiting faculty program because we were inspired by the program to do this work. And here is the list of this paper that was published in case you want to read it in detail and get more information about the studies. Thank you.
Thank you very much, Dr. Yu. That was very informative, and we certainly will have plenty of time at the conclusion of our next speaker for questions for you. Before we introduce our next speaker, I want to remind everyone that questions can be submitted at any time by clicking in the text box message at the bottom left corner, then type in your question and hit the send button. We will answer all the questions after our second speaker finishes her presentation. So at this time, I would like to introduce our second speaker, Dr. Yu-Sheng Jin. Dr. Shin is an associate professor at the University of Delaware School of Nursing. She obtained her doctoral degree from the University of Iowa in adult and gerontological nursing and a postmaster's certificate from the Duke University Adult Nurse Practitioner Program. She attended the Edmund J. Saffer Visiting Nurse Faculty Program at the Parkinson's Foundation in 2013 and has focused her work on symptom management in Parkinson's disease, including medication adherence and chronic disease management of later life. Dr. Shin has received extramural, intramural, internal, and NIH funding for her research. She has multiple publications on her work in Parkinson's disease and has presented her work at regional, national, and international conferences. She has also been a prior participant on our webinars when she talked about medication adherence. In 2016, Dr. Shin received the Excellence in Research Award from the Gerontological Advanced Practice Nurse Association, and she practices as a certified adult nurse practitioner at the University of Delaware Nurse Managed Primary Care Center and also the Parkinson's Disease Telehealth Center. We're happy to welcome Dr. Shin back for her second webinar, and I'm going to turn the program over at this time to Dr. Shin.
Thank you, Gwen, for the wonderful introduction. So, hello everyone, my name is Ju-Young Shin, and I'm happy to share my study, which is entitled Complementary and Alternative Medicine Use in People with Parkinson's Disease. So this slide is a repetition of the definition of the terms here. So when I started to design this study back in 2013 and 14, CAM was the traditional term for this area. And then in 2016, the National Center for Complementary and Integrative Health adopted a new term, which is complementary health approaches. The definition of complementary health approaches is a group of diverse medical healthcare systems, practices, and products that are not considered to be part of conventional or allopathic medicine. So after collecting my data for this survey, the term has been changed. So I just wanted to highlight that. And then here, as we know, Parkinson's disease is affecting at least 1 million people in the United States and requiring ongoing treatment. And CAM has been used both alone and in adjunct to pharmacological therapy to manage Parkinson's symptoms in some people with Parkinson's disease. The main reason I started to look into this area is based on the result of my previous study, medication taking behavior in people with Parkinson's disease. From that qualitative study, some participants reported that they are taking some CAM So they said complementary and alternative medicine use, and one particular individual reported that the person is taking more than 32 supplements. So that brought me to this area, and then I had the literature review done and found out this area has not been systematically studied in the United States since 2001. That's why I started looking into this area. And the better understanding of chem use would provide a foundation to help both people with Parkinson's disease and providers have dialogue about chem use. The purpose of this study was twofold. First, to describe the prevalence, types, and associated factors of chem use in people with Parkinson's disease, and secondly, to explore reasons for chem use. The study used a self-administered cross-sectional survey. The survey was developed by research team, including me, and then validated by the group of people with Parkinson's disease, and finally by a group of experts. The survey included 3 sections: socio-demographic, disease-specific, and chem. Chem sections included the list of these previous and current use of chem therapies, including 25 supplements and 29 modalities or therapies. The University of Delaware IRB was approved, and data were collected from community dwelling individuals with Parkinson's disease between March and December 2015. Data were analyzed by descriptive stats, t-tests, chi-squares, and logistic regressions were used. So the response rate was 61.9%. A total of 135 participants participated, including 80 males and 55 females. The mean age of the respondents were 69.7 years old. Mean years of education was 15.8 years. So my population was pretty highly educated, and then more than a half of participants reported their household annual income at $60,000 or higher, and respondents were mainly from the following U.S. states: Delaware, 43%, Indiana, 22%, Maryland, 20%, and Pennsylvania, 9%. So this slide shows the result of Parkinson's disease-related data. Participants were diagnosed with Parkinson's disease from less than 1 year to 24 years prior to the survey. 36 participants saw more than 2 healthcare providers for their Parkinson's disease. For instance, the majority of participants saw a neurologist, 62%, and a movement disorder specialist, 51%, for their Parkinson's treatment. All participants were taking at least one anti-Parkinsonian medication. Average was 1.91. Then I also surveyed their symptoms using the researcher developed list. But the mean of the number of symptoms was 13, including 3.86 motor symptoms and 9.17 non-motor symptoms. A total of 74.1% participants used chem for either PD or general health. So 70.1% prevalence was reported. 23% chem users used more than 10 types of chem. The recommendations for chem usage from their healthcare providers were higher than the findings of previous studies, such as PD specialist 32.6%, primary care providers, 28.9%. The associated factors of CAM use include higher level of education and treatment by a movement disorder specialist were significantly related to CAM use. And participants use the CAM for their general health and to delay the progress of Parkinson's disease. So this figure shows the CAMs used among 89 participants. So they were allowed to answer all that apply. So exercise, 61 out of 98 people said they are doing some exercise. So it's really consistent with the Dr. Yu's finding from the literature review. So my participants said they are doing boxing, bicycling, walking, or dancing. And yoga was the number 2, massage was number 3, deep breathing, vitamin D, multivitamins, and coenzyme Q10. Coenzyme Q10 was pretty a fashion back in days, and it's still utilized among people with Parkinson's disease, although this one study said it's not effective. So implications, findings of this study suggested CAM usage in the United States has grown since 2001. Nurses and other healthcare professionals have a role in providing coordinated and safe care for people with Parkinson's disease. Further studies on effectiveness and safety of commonly used CAM therapies are warranted. So this study was supported by the University of Delaware General University Research Award to myself. And these two, the third and fourth bullet points, indicate the publications from this data set. The third one is the use of complementary health approaches in people with Parkinson's disease was published in the Journal of Gerontological Nursing. And the last bullet point is highlighted the article entitled Beliefs about Use of Complementary Health Approaches for Parkinson's Disease. And we really wish to thank participants of this study, local PD support groups, National Parkinson's Disease Foundation, Michael J. Fox Foundation, and Parkinson's and Movement Disorder Center of Maryland. Thank you.
Thank you very much, Dr. Shin. Very interesting and stimulating conversation. And we have multiple questions, and it's time to let our audience questions be answered. So I am going to go over some of the questions, and some of them are addressed to one speaker versus the other, but certainly we open up to both speakers' input. Dr. Shin, one question that we have is that patients don't always tell their practitioner what complementary and alternative or supplemental therapy they are using. Do you have any thoughts on how we as healthcare providers can develop a more open attitude toward eliciting this history?
Could you repeat the question? The last part?
Sure. Oftentimes patients don't tell us what complementary or alternative medicines or practices they're using, or supplements for that matter. Do you have any thoughts on how we can develop a more open attitude to elicit this history from our patients?
Yes, I see. Yeah, I understand. The fourth bullet point, my second study out of this CAM data set explored why they didn't. The first question was, did you discuss this with your provider, yes or no? And people who said they didn't really share this idea with their usage of CAM with their care provider, mainly they thought the providers don't have time to discuss this, with them, or they thought the healthcare providers, they don't acknowledge the use of CAM. So as a practicing practitioner, I think if we ask the questions like, what kind of supplements do you use? So more open approach to them, and probably some of them will open to discuss what they've been using in terms of to delay Parkinson's disease progression or general health. That's one thought. Yeah.
Thank you very much.
You're welcome.
Dr. Yu, we had a question on your study interventions. A question from the audience. It seems like exercise was mentioned, and did you get the effect that it was the most efficacious in your study, or was it just the numbers that portrayed that?
That's a very good question, because we didn't specifically focus on exercise, but we know when we did the literature review, we found a couple review articles that specifically focused on exercise. So if you would be interested, there are references out there that you can search. But in general, what those meta-analysis or systematic review paper have found out is exercise actually is very effective for a range of symptoms in Parkinson's disease, not necessarily on quality of life, but they do show demonstrated effects on motor symptoms and non-motor symptoms. And the range of exercise that have been tested so far are very broad, which is very encouraging. As I mentioned earlier in my presentation, they include the endurance exercise, strength training, balance, boxing, dancing, and typically they were testing one single modality of exercise, but also there are trends to show that combined exercise of different modalities may actually have a concerted or even synergistic effect.
Thank you very much. I think the day is going to come that most likely we will consider exercise not a complementary or alternative at all, but really a mainstay in the treatment of Parkinson's. It really is getting to be shifted into that arena more each year as we learn more from research studies.
I completely agree.
Right. Here's another question related to the different types of exercise, Dr. Yu. One of our listeners was interested, are yoga and Tai Chi better or equal to physical therapy? If a patient had the option, I guess, to do one versus another, do you have any thoughts on the quality of life impact of Tai Chi and yoga versus physical therapy?
Oh, that's, again, a very great question. Truthfully, when you look at the different interventions, what you need to do first is to look at the patient. And what are the major symptoms a particular patient is having, because there is symptom variability across patients. And we want to identify the most effective exercise modality based on that person's symptoms. So if that person's symptom is mainly related to balance type of activities, mobility issues, then Tai Chi will probably work the best. And if we are trying to target non-cognitive symptoms or behavioral symptoms, then yoga probably is the option to go first with. In terms of physical therapy, currently in our culture, you do have to have medical indications to get physical therapy, and then you are referred to the physical therapist. They help you set up exercise program, which you can do on site or you can do at home. So I think a first referral to physical therapy is probably a very good idea, so you can get set up with the appropriate exercise. But later on, you can probably do them yourself if you want to or continue to work with the physical therapist. As far as which works the best, is again goes back to what symptoms are you trying to manage.
Thank you very much. I know being in the clinical arena, we always think physical therapy first to evaluate the safety and really get the patient set up on a program that's going to be safe for them. So that's a one-on-one kind of therapy. But we certainly do then encourage group exercise such as yoga and Tai Chi, which have been shown to be so good for the balance in Parkinson's disease, as long-term exercise programs. But safety first, we always think of. Dr. Shen, in your studies, your people that were using complementary and alternative medicine stated that they were using it for either the general health or to delay the disease progression. Since we have no known disease-modifying options at this time, with the exception of perhaps exercise, what can we do to clarify the myths? We noticed that people were still using, for example, coenzyme. Was that one of the things that they were using in hopes of delaying the disease progression? And should we really evaluate the patient's beliefs and the reasons they're using therapy more thoroughly?
Yes, I agree, because people are really looking for so many things, such as coconut oil. Some people reported they are using coconut oil to delay Parkinson's disease symptom progression. So that's why our research team thought we need more rigorous research to evaluate what's the effectiveness of all those things. Some products out there, natural products out there, have some neuroprotective effects, such as antioxidants, but it's not really based on rigorous scientific research. But people still have all those things. And then when people told me some companies out there are really promoting, and they just sound like it's really effective. But some materials have levodopa, some kinds of levodopa from natural products. So all those things, we have to be really cautious about the ingredients of natural products and on the market. Yeah.
Right. And always talk with your provider about the true science if it has been studied, because I think marketing sometimes advertises things as being something that they haven't been shown to do in research studies. So it's always good for patients and families to check with a practitioner as well. Here's a question from our audience about finding practitioners, and really I'd be open to both speakers answering this question. If you're looking for a good practitioner, such as an acupuncturist or reflexologist, that sort of thing, any thoughts on how one can find a qualified one?
That's really a good question. And when I asked about their beliefs and how they choose the practitioners, people are just Googling and really relying on the information from website. So, but in that case, I think we can encourage the people with Parkinson's disease and their family members to check the credentials. The chiropractors, they have their own credentials, and acupuncture, all those things. And before they make scheduled appointment, they can ask them what kind of qualifications they have as a practitioner out there. That will be the one way to validate. But I don't know how we look up their information for each practitioners. Yeah.
Right. It does get quite difficult. I know if you're looking for example, a speech therapist that's trained in the Lee Silverman program, which is a specific program for Parkinson's disease, you can go on their website and put in your zip code and find who in that area has been credentialed and trained in that technique. but it does get a little bit more difficult for some of the other areas such as acupuncture and reflexology and that sort of thing.
Yes, that's what I found, from my research.
Okay. Here is a question about your study, Dr. Shin. Did you find that the length of a person's Parkinson's disease correlated in any way with their use of CAM?
Could you repeat the question, please? Sorry.
Sure. Did you find that the person's length of having Parkinson's disease correlated in any way with their use of complementary and alternative therapies?
No, that wasn't supported by the study, this data set, but there was a trend that the number of symptoms were related to, it showed trend but not statistically significant, but number of the Parkinson's symptoms were related to more use of CAM. So there was some trend there.
A sort of trend, but nothing.
Yes,
nothing.
Yes,
specific.
and as we know, with the longer duration of Parkinson's disease, people will develop more symptoms likely. So I guess it could be a trend, but I didn't find any findings from this data set.
Thank you very much. Thank you.
Yep.
Dr. Yu, I noticed on your slides when you were describing the study locations, a majority were in the United States. And I wondered myself if that you think there are more studies in non-pharmacological approaches to Parkinson's in the U.S., or is it that these researchers are publishing more, or could it be the criteria for your study ended up just reflecting those studies that were fitting the criteria, and a lot of them came from the United States?
I think this question, you really nailed it on the head. The general answer is we don't know. At this point, I think based on what we have found, that there are simply not enough studies across the globe to look at non-pharm interventions for improving quality of life. As far as why more study in the United States, I think that might be related to the fact that we do have this separate institute that advocates for complementary and alternative therapies, and also United States in a way has been leading the way for patient-reported outcomes and how they should be measured and why they should be measured. But I think in Europe, they have made highways on a variety of different interventions that are broader in range. So it's very important, because the other way to think about it is those complementary therapies, many of them have a region in Asia, and they have been used in practice. However, the research base has not come along to support their uses yet. And part of that is whether or not they are conducting studies and were able to publish them. And that's probably one of the major issues. And this also circles back to your very first question that the audience asked about how do you get patients to tell you if they are doing any of those, and how do we make sure the practitioners are prescribing those non-pharm treatments. I think one of the fundamental way for us to change it is to make it part of the intake or prescription smart set that the physicians are writing or providers are writing. So that way they are attuned to the non-pharm interventions and know to prescribe them because they are in the electronic health records.
Great, thank you very much. Thank you. Dr. Shin, this is a question for you.
Yep.
And as a practitioner, I know you see a lot of people with Parkinson's disease. Do you have any tips for overcoming fear? If you really think exercise might be of benefit to a person and they're a little hesitant, maybe they fear that they might fall or have an injury, do you have any tips for talking with folks about their fear and before they get involved in exercise programs?
Yeah, the fear of falling and falls are really major barrier to get into exercise. But I should say safety is the first thing. So before anyone starts the exercise, if they have any unsteady gait or any issues with balance, they should be evaluated first by a physical therapist. And then they can go on to any exercise. In one limitation of my data set was we didn't really ask them if they were prescribed by any experts for exercise or they are just picking up any kind of exercises by themselves. So that's unknown area. But I should say safety is the first thing we have to really take care of. So that's just my gut feeling. Yeah.
Yes. I would agree with you. I think there is a lot that a therapist can do to really enhance one's confidence and safety. So oftentimes that precedes really getting involved in group programs and ongoing maintenance programs. The person has to feel safe. So thank you very much.
You're welcome.